today we have a TAVR case, and we are going to use Vienna 29 valve. And today we have our structure. You can switch off this light. Switch off this light. Today we have our structural specialist and very close friend of mine, Dr. Anantaraman. He is going to give us tips and tricks about this TAVR case. And go to the first case, first slide. It's a 73-year-old female patient, known hypertensive, present with occasional episode of giddiness and exertional dyspnea. We did angio evaluation about 10 days ago. Angio was, it was not revealing any significant coronary disease. Go to the next slide. So echocardiogram, you can see the gradients. Echo gradients almost 90 systolic gradient. Go to the next. Now this is angiographic evaluation. Angiogram, no significant disease. Go to the next. So whether to go for surgery or TAVR, this patient, because 73 plus female patient, we thought TAVR is the ideal procedure. So angiographic analysis showed there is a reasonably good sized peripheral access, and calcium is moderate, about 470. Calcium score 470. Calcium distribution more along the non-coronary cusp and right coronary, less on the left coronary cusp, and the height of the coronary is very good, 13 on the right side, left side 14 mm. So the depth of the sinus valsalva adequate, more than 29 mm. So here the chance of coronary obstruction is very low, and there is no significant calcium in the LVOT distribution, and because LV size, the annular diameter is coming to about 22.9, and LVOT is about 24. So reasonable good size LVOT, and other anatomies are fine. And I will ask Dr. Already we have accessed the left femoral axis and right femoral. Left femoral artery, we kept it for pigtail, and we also kept the pigtail temporary pacemaker through the left femoral vein approach. We accessed the right femoral artery. Initially 7 sheath was inserted, and we inserted 2 prostyles, 12 o'clock and 10 o'clock position, and we have placed the 16 French sheath, and now we are ready to go ahead. Already we acquired the pigtail injection, and this is a horizontal aorta. Because the horizontal aorta, the plane of annulus to the plane, horizontal plane is about 69 degrees. That's the reason prophylactically we have kept the mainly we anticipate a difficulty in crossing the wall. That's the reason we have kept the 30 mm even snare also to retrieve. So next I would like to request Dr. Anant to discuss in detail about the case and to throw some more insights of the case.
Thank you, sir. Just go back and show the CT, please. Yeah. So here, obviously, the left top corner, this is the most important. This is the annulus sort of measurements. So you have a perimeter around 73, and the area is sort of around 400 plus. So the perimeter derived is coming around 23, and the area derived is 22.8. And this patient is around 70 plus. So we want to talk about the lifetime management. That is the most important thing. Now when we do TAVI, it's about the lifetime management. And then the second thing about the anatomic suitability. So for surgery also, she will fall into a low risk surgical candidate, and for TAVI also, she will be a low risk TAVI candidate. For the lifetime management, for her body surface area, she is around 75 plus kg, body surface area is more than 1.7. We want to give a valve which will have a larger effective orifice area. So if we use a balloon expandable, we'll use a 23 here. If we use a self-expandable, we are going to use a 29. So that is the reason behind using a self-expandable, which will probably last her life. In case if this valve degenerates in about 78 years or 10 years down the line, we can still go and put a balloon expandable sort of as a TAV in TAV, because the coronary height and all the diameters are good. So the selection is the self-expandable 29 valve. There are various platforms available. We'll discuss about the platforms. Now coming to the right side, the STJ height is good, the ascending aorta is good, coronary heights both sides are more than 14, and the STJ diameter is more than 30. So we will not get any coronary obstruction. So the major sort of factor is the horizontal aorta. It's almost 70 degrees. When you see it 70 in the CT, most of the time once we cross, it looks like 90. So it is proper horizontal. We'll show it. It is proper horizontal. So the horizontality means among the self-expanding platform that is available in India at the moment, there are 4 of them is there. So Abat one is a highly flexible, and then the Evolute FX is flexible. So those cases we probably can take a 90-degree angle, but still better to keep a snare as a backup in case if there is issues. Couple of other platforms, obviously the Relicis is a valve which we are going to use. So the advantage of Relicis, you don't need a clinical specialist to prepare it. You just take it like a stent, wash it, and then use it. That's it. So for emergency cases where you don't have time, this is probably the best valve. The second advantage, because it's a dry tissue, obviously it comes prepared in the company. The previous version, there was a little bit of stiffness to the delivery system. The current version, it is flexible. So we are going to see the flexibility of the current generation. In this case, we will not use the snare up front. We will try without that and see the crossability. If there is difficulty, then we'll bring back and snare it and then use the snare assistant to cross. So that's the logic behind keeping the snare ready. If you think there is going to be difficulty, it's better that you keep the snare cross through that, because once you predilate the valve, sometimes you get acute AR. That time it will be difficult to rush in and do things. So if you are anticipating any difficulty, keep a snare. If you use it, otherwise you can always remove. So the only sort of disadvantage is one more additional access like this one, left radial. Otherwise there is no other major disadvantage. So that is the basics. Go to the next slide, please. So this is the annulus and the LVOT. So in this case, if the LVOT is smaller than the annulus, because the perimeter is 73, if the LVOT, for example, was 70, I would have used a 26 valve. So the LVOT is larger here, it is 74 than the annulus. That is the reason we are using a 29, because the 73 perimeter is a cusp where you can use a 26 or a 29. Based on the LVOT, we decide. So if the LVOT is larger than the annulus, we use the larger valve. So we are going to use a 29. If the LVOT was smaller, we would have used a 26. Next, please. So the predilatation will be 18 because the minimal diameter was 19. So we'll predilate with an 18. It's a tricuspid valve. And next, please. There is moderate calcium in the leaflet. People will ask, why do you want to predilate? Because there is moderate calcium. Obviously, you can go without predilatation, but sometimes recapturing does have a downside. When you start recapturing, the infolding as well as the conduction abnormality is more. When you predilate, you probably don't need to recapture. You might get in the first time itself deployment. So that is the reason. And predilation is always better than a post-dilatation. Next, please. So that shows the calcium distribution. There is some calcium in the arch as well. We'll try to avoid that calcium. And the valve calcium is there, which will hold the valve. Next, please. And this is showing the horizontal aorta. It's around 70 degrees, but it's more horizontal once we crossed. It looks like 90 degrees. Next, please. So the femorals are adequate. Femorals are more than sort of 6 to 7 here. So for this particular valve, you need it's a 16 French. So you need at least a 6 femoral. Around less than that, probably it's better not to try directly. Sometimes surgical contour is better. So next, please. Yeah. So there is no significant calcium. There are some small specks of calcium. Otherwise, no significant calcium. The left femoral is high bifurcation. So it was ultrasound guided puncture, and it is just above the bifurcation. The right is below the sort of femoral head. So it was fluoro guided. So the puncture is already taken. Next, please. So the current setup as Sarah has shown is, so the right side is the main working axis. We have two proglides, 16 French sheath is already there. We've taken an AL1 straight wire, crossed it, and then a double length J wire. Now the pigtail is in the apex. On the left side, we have a 7 French sheath through which the pigtail is there, and then the TPI is there through the 6 French. And the left radial is shown through which a JR4 guide is there, and a snare is parked in the thoracic aorta through which we crossed. So it's ready. So the next thing we are going to do is we'll put a Safari extra small wire in the LV, and then predilate,
balloon ready,
and then take the valve. So the ACT is already checked. ACT was 280, so we given additional 1000. We are rechecking the ACT before putting the stiff wire. The invasive gradient is coming around 60. You can see it in the hemodynamics. The invasive gradient is around 60. The echo mean gradient was more or less the same. So the invasive gradient is similar to the echo mean gradient. So that's another thing. If the echo sort of invasive gradient is more than 50, it's better to predilate. It makes your valve implantation much safer as well as much comfortable. So the Safari extra small wire will allow you to move the wire inside the LV freely so that you can adjust it when you're taking the valve. Previously, we used to use Lunderquist for all these cases. Lunderquist has its own downside, so it's better to use Safari extra small, which gives the flexibility of moving it inside the LV.
Ready?
So we stay in RAO because you want to see the true apex and you place the wire in the apex. After that, we can go to the working view, that is a coplanar view, and the valve deployment in the cusp overlap and then in the coplanar. You see that it's become now 90 degrees horizontal. Yeah, store that. So this always happen. It will face down and then it will flip on its own. Now it's perfectly positioned in the apex. Walk it out, please.
Position.
Yeah. So maintain that position. Yeah, beautiful. So when you cross through the orifice, then when the wire comes to the commissure, it will be closer to the non-coronary pigtail. So it should be closer to the non-coronary pigtail, go down and face in the apex. That's a good wire position.
Balloon, 18.
Yeah, some ectopics is causing the low blood pressure. We'll sort it out. No, don't worry. Fluoro. So once I pull the wire, the ectopics will settle. You can start a small dose NORAD, yeah. Give the balloon, please. Valve is prepared, ready, yeah? Okay. Yeah. Fluoro, yeah, just 1 second. Fluoro. Yeah, that's okay. Okay. Fix the wire, ma. Fix. You hold this. I'll just hold the wire. It is tight. Okay, so what length is this balloon? Looks short. Go to the LA view, coplanar view.
I think I've been fine.
Yeah, center it. That's okay. That's good. Ready? So who is going to be in pacing? Oh, no, just you can go.
Until the waist clears.
Until the waist. I'll tell you.
Pacemaker చూసుకుంటా.
Okay, sir. Cine, sir.
Yeah, on.
Pacing on.
On.
Yeah. Go up.
Yeah,
balloon
go
up, 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 up,
And play.
up, up,
And play.
up, 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 up. Push
Pass,
it, push it,
pass,
push
pass,
it.
pass.
Push it, ma. Down.
Pull, deflate.
Okay, balloon down. Facing down.
Facing. Yeah.
So unlock, push it. That's okay, it's opened right up. Let's walk it out. Bring the valve and cut the suture in that one, the sheath suture. Out, sir?
Yeah.
Hold
out.
the wire. Yeah.
Out.
Give some light for sir.
With a light in.
So
with the light on.
Proglide. Watch.
Not proglide, this one. Right. Now it's clear.
Come, huh?
Yeah.
Okay. So if you press, I will walk it out.
Yeah.
Fluorosa.
Fluoro, 1 minute. Yeah,
Okay, I'm walking it out.
yeah.
Bring the valve to the table. Who is that chatting? Go out.
Ready.
Bring the valve to the table.
It's okay.
Feed the valve.
Oh.
So this has an inline sheath like the Medtronic, but it's slightly bigger, that's all. Okay, so hold it here.
Yeah.
And take it, so wire fixtures control.
Hold the wire.
Yeah, now it will go. Yeah, all the way. Yeah. Okay. Now little bit in, so that we'll get the stop there. Now we can connect the pressure to this. Pressure open, huh? Two pressures, yeah, good.
I think air is there. We'll remove the air.
Oh, 1 second. Give one flash syringe, please.
That's fine.
Okay, that's fine. Good. So position the table, release the
Oh,
table.
give me a dry gas. It's there. Right.
Release the table. Fluorosa.
Shall I
Lock the
proceed?
table. 1 second, sir.
Lock.
Lock the table. Okay, first we'll try without the snare.
Yeah.
You take it. If it's not, then we'll
Not
support
going,
it.
then we'll take this one.
Wait, sir, don't push too hard. No,
Yeah.
no, no.
Then we'll.
Now we need snare. Store that fluoro. Store the fluoro. It's going headwards.
Shall I pull it slightly?
Wait, sir. Let me tighten the snare. Oh, just move the torque. Move.
Okay, torque moving. Back.
Close to my finger. Close to my finger. No, tighten it complete. I'm holding it. Tighten that.
Tight.
Take it closer and tighten it. Okay.
Right.
I'll hold it, sir, and then.
Shall I advance now?
Fix the wire. Wait, sir. It's slipping. It is slipping. Okay, sir.
I think still you have to pull it, I think.
Yeah.
Now it's going.
Yes.
Now it's going.
Yeah. So that's the thing it needed. Now try it, sir.
Slightly
Otherwise,
push the wire. Advance the wire slightly.
Try it. Otherwise, you'll have to snare it again.
I think it will go now. No, I think
it will go, sir. Slowly. The nose cone will go. Stop.
Yeah, got it.
Store that. Let me reposition the pigtail. It should not be underneath and all those things. Okay, fluorosa.
Yeah, fluoro on. Right.
No, it's completely caught.
You want wire? Huh?
Give the wire, ma.
Wire band, ma. Pigtail wire. 035.
No, it's outside.
Yeah.
Hold the wire, ma. Hold the wire tight. No, it's buckling somewhere else down. Show down.
Otherwise, we'll come down and push it again. Slightly. Pull your side. Okay.
No, come to PA and show the groin.
Be a groin and show the groin.
Let me see where it's catching. Okay, go back to the top. Now go to the LAU.
Now it's gone. Alright, shall we take step file? We'll take step file.
Amplets in them.
Ampler CPM. Zero.
Now show the arch.
Arch.
Keep it there. Don't move the table. Pass the wire.
That's it. One minute. I'll
Moving,
push.
sir.
Yeah, moving. Just pull the wire. I think it will go. Yeah. Pull the wire. It may go, I think. Otherwise, shall we totally withdraw and push it again? Now it's fine, I think. I think somewhere it's looping.
Yeah.
Because
Okay.
length
One
is.
second, sir. Let go.
We'll withdraw totally and push it.
Now you give me the wire, ma. Take it, sir. It's not going, huh?
Not going.
1 second, sir. Fluoro. Try that. Yeah, it's coming in that inner curve. Take it now.
Yeah. No, it's not going at once. Somewhere it's stuck.
Yeah, try that.
Now it's going.
That arch, there is no space.
No space, that is. I will try once.
Yeah.
No, it's not going. Shall we withdraw totally and replace? Alignment different. Yeah, gone.
Okay. Just close that. Forward this. Aspirate. Okay. Don't do anything in that. Because
You want 10, huh? Injection?
Because this is open. Close it. Yeah, now take it out. With the flash. Okay, let's sort out the valve. We'll do that later.
We'll take injection?
Yeah. Ready for injection?
Ready for injection.
Sinisa.
Ready, huh? On. Slightly we have to go down, I think.
Yeah.
Shall I advance?
Yeah, little bit. Enough, sir.
One
One more injection.
One more injection. Ready, huh?
Yeah, give please. Yeah. First, let me release the valves and then we'll get.
Dry gas. I shall hold it up.
Yeah.
Yeah, you can.
It's a messy valve release. Is it opening?
Yeah, opening. Yeah, opening. Shall we give one more injection?
Is it opening?
Yeah, opening there.
No, I'm not seeing any movement. I'm not seeing anything. It's not moving.
Total delivery system.
No, it's not moving. Go away. I knew that. Fluorescent.
Okay. I'll hold this one.
Wait there, sir. No, it's disconnected, sir. This delivery system is not opening and closing. No.
Yeah, it's not. No, I'm holding.
Sorry, hold the sheet.
I'm holding. Shall I hold this one?
No, it's okay.
No,
ready
everything should
ready
be
with the
removed,
sheet.
huh?
Yes, sir.
Next sheet ready, Vincent. Keep next sheet ready.
Sheet ready.
We stopped this case in between. Ready, brother? No, all of you keep quiet. Then I will start. Okay? All of you keep quiet. This is a very complex anatomy due to horizontal aorta. We faced many problems. Even first device malfunction was there, but again it retrieved and we went ahead with the second device. Now I request Dr. Anantharaman, what are the difficulties and challenges we faced while doing this case, mainly through to throw some of the highlights of this case. Over to you, Dr. Anantharaman. Yeah.
So obviously, when there is a complexity with the case, and also sometimes when there are some issues with the device and system, first thing is we say we should keep a very clear mind. Should not rush or do things where we hit or harm the patient. So the first thing is because that device was not releasing, we had to remove the device. Device was removed. Then we assessed the whole anatomy. We did a iodogram, make sure the aorta is there is no other issues. Wire pressure was confirmed. Then we tested the new device outside to make sure it is the opening as well as the recapturing. Once that is done, then we went with the new device. Again, through the snare, show this fluoro please. So the snare was, well, the first time itself it was only snare assisted. We can get it across the arch. Next slide please. So the snare was placed in the upper 1/3. Next please. As the system was coming near the arch, a good tug was given. So that as it said, next please. Once it was across the arch, then it was fine to meditate. Now this system is different compared to the previous system. This anatomy was different. Looks like a pseudoprotection with the flexion of the aortic arch. That's why it was struggling. Irrespective of the system or other system, even the Anatomical and Navica might have struggled in this aortic anatomy. So the test for this system is now from the ascending aorta going into the annular. How does it behave? Does it behave with the snare or without the snare? That's what we are trying to see. 90% horizontal you can see. We are not using the snare assist at this point. Next please.
Sterilium.
Next please. So here, without snare assistant, system is flexible. We are able to meditate. So okay, fine. So I don't think the been the distance issue. The been any system would have struggled to go through that complex anatomy. Thoracic aorta to the arm to the quiet. So it was a good idea to go with that, but where the annular is and where the horizontal is, I think the was best. We have to do that.
Fluoro, it got disconnected. Call that guy. Now it's coming. Yeah. Hold it like that.
With this horizontal aorta, the dorsal ventricle, with the wire,
మళ్ళా పోయింది. Forward, forward. Not moving. Where do from there? Now.
All the access is closed. The EPI is remove of this charge. No one is
Yeah, thank you, Dr. Anandraman, for showing many highlights of this case. This is a very complex anatomy with a horizontal anatomy. Actually, we started case at 9 o'clock. It took almost 2 hours 45 minutes because the snaring, device malfunction, retrieving and putting second device. Finally, end result is excellent. So I'm also thankful to my associates, Dr. Aparanji, Kavya, and all the technical staff for helping in conducting this wonderful case. Thank you once again, Dr. Anandraman. Thank you very much. And